The patient in room 9. Dr. Layla Osman had been a hospitalist for 8 years. She covered the general medicine ward on overnight shifts 3 times a week. She knew the ward the way you knew any place you had spent thousands of hours in. Its rhythms, its sounds, its particular population of patients on any given night. She was not a person who made assumptions about patients. She had learned early in her training that assumptions in medicine were dangerous, and she had built her practice around the discipline of looking at what was actually in front of her rather than what she expected to find. This discipline was what made the patient in room 9 so difficult to dismiss. He had been admitted 2 days before Layla's shift with a set of symptoms that had produced a long differential diagnosis and not yet resolved into a clear picture. Fatigue, intermittent confusion, elevated inflammatory markers, a low-grade fever that came and went without obvious pattern. The kind of presentation that kept physicians honest because it refused to be tidy. She reviewed his chart at the beginning of her shift and went to introduce herself. He was awake when she came in, a man in his 50s, well built. The kind of physical presence that still came through clearly even in the diminished context of a hospital bed. He looked at her when she entered with eyes that were alert in a way that did not match the degree of confusion documented in the notes. She introduced herself and told him she would be covering his care overnight. He thanked her. His voice was measured and pleasant. She ran through the standard questions. How was he feeling? Had he eaten? Was his pain managed? He answered each question precisely and appropriately. Then he asked her one. He asked her what she thought was wrong with him. This was a standard patient question, and she answered it in the standard way. She explained that they were still working through the investigations, that they had a number of possibilities they were pursuing, that she hoped to have a clearer picture for him soon. He nodded. He said he appreciated her honesty. He said most physicians were more comfortable with uncertainty than they admitted. She agreed that this was sometimes true. He said he found the body's ability to conceal illness remarkable. The way a person could carry something serious inside them for a long time before the surface gave anything away. Layla noted this comment without reacting to it. She completed her assessment and told him she would check in again later. She was writing up her notes at the ward station when the night nurse came to find her. She said the patient in room 9 had requested his personal belongings from the storage locker. Standard procedure was to retrieve personal items on patient request. Layla noted it and continued her documentation. 30 minutes later, the nurse came back. She said the patient had asked her something unusual. He had asked her how long it took for activated charcoal to clear the system. Layla put her pen down. She went back to room 9. He was sitting up in bed with his hands folded. He looked at her when she came in with the same alert and measured expression. She asked him directly about the question he had asked the nurse. He was quiet for a moment. Then he said he was a curious person. He said he had always been interested in how things worked. Medicines, the body, cause and effect. Layla looked at him. She looked at the personal belongings bag on the chair beside his bed. She asked him if she could look at his belongings. He said of course. She looked through the bag. At the bottom, beneath his phone and his wallet and his reading glasses, was a small glass bottle with a handwritten label she did not recognize. She picked it up. He watched her. She asked what it was. He said it was a supplement, something he took for energy. She looked at the bottle. She looked at him. She took the bottle with her when she left the room. She sent it to the laboratory for analysis. The results came back at 4 a.m. She stood at the ward station and read them twice. The bottle contained a compound that the laboratory identified as a derivative of a substance used historically as a slow-acting toxin, not available commercially, not something a person acquired by accident. Layla looked at the chart, at the symptoms that had brought him in: fatigue, intermittent confusion, elevated inflammatory markers, a low-grade fever that came and went without obvious pattern. She read the notes again. She thought about what it meant that a person had been admitted with symptoms consistent with slow poisoning and had in their possession a compound consistent with a slow-acting toxin. She thought about who the compound was for. She went back to his room with 2 colleagues and asked him that question directly. He looked at her for a long time without speaking. Then he said something she had not expected. He said it was for himself. He said he had been taking it for 6 weeks. He said he had wanted to understand what it felt like from the inside. He said he was a researcher, that he had been studying the compound for years, that he had reached the point in his research where he felt direct experience was necessary for complete understanding. Layla stood in room 9 at 4 a.m. and looked at a man who had been slowly poisoning himself in the name of understanding what slow poisoning felt like. She did not have a clinical framework that adequately covered what she was looking at. She called the on-call psychiatrist. She flagged the case for the toxicology team. She documented everything, but the thing she thought about most in the days that followed was not the compound or the symptoms or the long process of treatment that followed. It was the expression on his face when she had found the bottle, not fear, not guilt, pure and complete and unsettling curiosity. The expression of a person for whom the boundary between studying something and becoming it had dissolved so gradually that they had not noticed it disappearing. The second opinion. Dr. Marcus Webb had been a pathologist for 22 years. His job was to look at tissue samples under a microscope and tell other physicians what he saw. He was good at it in the specific way that came from 2 decades of looking at cells until they gave up their secrets. He had developed an eye for the subtle and the unusual that his colleagues trusted completely. He was not a man who second-guessed himself, which made the case of the samples from room 14 so difficult to process. It began ordinarily enough. A set of tissue samples arrived in the pathology lab on a Wednesday morning. Standard biopsy request from the oncology ward. The patient was a woman in her early 40s who had presented with a mass in her left lung. The clinical team needed confirmation of what they were dealing with before proceeding with a treatment plan. Marcus prepared the slides and sat down at his microscope. He looked at the first slide. He adjusted the focus. He looked for a long time. Then he sat back. He looked again. The cells on the slide were not normal. This was expected. Biopsied tissue from a suspected mass was not expected to look normal. But the cells were not abnormal in any way he recognized. He had looked at thousands of lung biopsies over 22 years. He had seen every major category of lung malignancy and most of the rare ones. He had a comprehensive and detailed internal library of what diseased lung tissue looked like under magnification. What he was looking at did not match anything in that library. The cells were arranged in a pattern he had never seen before, not chaotic in the way of aggressive malignancy, not the slow creeping pattern of less aggressive disease, something else entirely, a structured and deliberate looking arrangement that reminded him less of disease and more of something organized, something almost intentional. He prepared a second slide from the same sample. He looked at it for a long time, the same pattern. He called in his colleague, a woman named Dr. Patel, who had 15 years of her own experience and whose opinion he respected without reservation. She sat at the microscope and looked at the slide. She was quiet for a long time. Then she said she did not know what she was looking at. She said it was not any malignancy she had encountered. She said the cellular arrangement was unlike anything she had seen before. They sent the slides to a specialist center in the city for a second opinion. The specialist called back the following day. He said he had shown the slides to 3 colleagues. He said none of them could identify what they were looking at. He said the cellular structure was unlike anything in the current pathological literature. He asked where the sample had come from. Marcus told him. The specialist was quiet for a moment. Then he asked if the patient was still in the hospital. Marcus said he believed so. The specialist said he would like to see her in person. Marcus went to the oncology ward to speak with the clinical team. The ward nurse looked at him when he asked about the patient from room 14. She said the patient had been discharged that morning against medical advice. She had simply gotten dressed and told the nursing staff she was leaving and had walked out before anyone could intervene properly. Marcus asked if they had a contact number for her. The nurse pulled up the file. The contact number was there. Marcus called it. A recorded message told him the number was not in service. He looked at the patient's home address in the file. He drove there that afternoon because he could not explain why, but he felt he needed to. The address was a residential street in the suburbs. Ordinary houses, ordinary gardens. The house listed in the file had a for sale sign outside it. He rang the bell anyway. A man answered who introduced himself as the estate agent. He said the house had been empty for 6 months. Marcus looked at the address in the file again. He looked at the house. He thanked the estate agent and went back to his car. He sat in the car and thought about cells arranged in a pattern he had never seen before. He thought about a patient who had walked out of the hospital the morning after her samples had been sent away. He thought about a phone number that was not in service and an address that had been empty for 6 months. He thought about the specialist's 3 colleagues who had looked at the slides and found nothing in the entire body of pathological literature that matched what they were seeing. He went back to his lab. He prepared a final slide from the last remaining portion of the sample. He sat down at his microscope. He looked at the cells. They were arranged in the same structured and deliberate pattern. But something was different from the first time he had looked. He increased the magnification. He leaned closer. The cells were the same, but the arrangement had changed. The pattern that had been there on Wednesday was not the pattern that was there now. The cells had reorganized, not randomly, not through any process of degradation that preserved tissue underwent in storage. They had reorganized into a new pattern, one that took him a long moment to understand, because what he was looking at under the highest magnification his microscope could produce was not a random cellular arrangement. It was not a disease pattern. It was not anything in the literature. It was a grid, regular, precise, evenly spaced, like the cells were arranged into rows, like something had organized them deliberately while they sat in a sealed container in a locked laboratory, like something inside the sample was still working, still building, still doing whatever it had been doing inside a woman who had walked out of a hospital on a Wednesday morning and disappeared without a trace. Marcus sat at his microscope for a very long time. Then he sealed the sample in a secondary container, labeled it with every warning designation available to him, and placed it in the deepest storage unit in the pathology department. He filed a report with language that he revised 4 times before submitting because he could not find clinical terminology that adequately described what he had observed. He never found the patient, nobody ever found the patient, and the sample in the deep storage unit stayed where he had put it, sealed, contained, labeled. But Marcus checked on it every week for the following 3 years without telling anyone why, because he needed to know if the arrangement inside the container was still changing. It always was, always reorganizing, always building towards something he did not have the framework to understand. Patient as a thing that had nowhere else to be, and all the time in the world to get there. The first nurse to notice it was a woman named Grace. She was doing her morning rounds on Ward C when she noticed a faint smell near the bed of a patient in the corner room. She could not place it immediately. Something sweet, faintly chemical underneath the sweetness, not unpleasant exactly, but wrong in the specific way that something out of place in a familiar environment was always wrong. She mentioned it to the ward sister. The ward sister came and stood in the doorway of the corner room and sniffed. She said she could smell it too. She said it smelled like almonds. The patient in the corner room was a man named Arthur. He was 73 years old. He had been admitted following a fall that had resulted in a minor fracture. He was otherwise in reasonable health for his age. His recovery was progressing normally. He was asleep when Grace noticed the smell. The ward sister checked his chart. Nothing in his medication list that would account for an unusual smell. No dietary notes. No documented history of metabolic conditions that might produce unusual body odor. She noted it and moved on. The following morning, Grace noticed the smell again, stronger this time. She stood at the foot of Arthur's bed and looked at him. He was awake and in good spirits, cheerful in the slightly performative way of patients who had decided that cheerfulness was the correct public posture for a hospital admission. She asked how he was feeling. He said he was very well, thank you. He said the nurses had been wonderful. She asked if he had eaten breakfast. He said he had. He said the porridge was surprisingly good. She said that was good to hear. She documented the smell again in her notes and flagged it for the physician. The physician came and assessed Arthur and found nothing concerning beyond what was already documented. He said some medications could produce unusual smells as they were metabolized. He said it was worth monitoring, but not alarming. Grace accepted this and continued her work. On the 3rd morning, the smell was strong enough that she noticed it from the doorway. She went in and stood beside Arthur's bed. He was asleep again. She stood there and breathed the sweet almond smell and felt the quiet insistence of something she could not name. She went to the ward computer and did something she had not done in 15 years of nursing. She searched the smell, sweet almond patient. The results loaded. She read them again. She walked back to Arthur's room. She picked up his chart. She went through every documented item in his possession, every medication he had declared on admission, every food item brought in by visitors. Then she looked at his bedside table, a glass of water, a paperback novel, a pair of reading glasses, a small tin that she had assumed contained throat lozenges. She picked up the tin. She opened it. Inside were small pale sweets wrapped in clear paper, the kind sold in old-fashioned sweet shops, the kind that had been popular in the 1950s and 60s. She unwrapped one and looked at it. She did not put it in her mouth. She took it to the physician. He looked at it. He smelled it. He sent it to the laboratory. The laboratory called back within the hour. The sweet contained a compound that the laboratory identified immediately, cyanide-based, derived from amygdalin, present in concentrations that were not lethal in a single dose, but that accumulated in the body with repeated exposure over days. The laboratory technician asked the physician how long the patient had been consuming them. The physician asked Arthur. Arthur looked at the physician, then he looked past the physician to where Grace was standing in the doorway. He told them he had been eating them for 3 days. He said his wife had brought them in on the day of his admission. He said she brought them every time he was in hospital. He said she knew they were his favorite. Grace looked at Arthur. Arthur looked back at her with the cheerful and slightly performative expression he had worn throughout his admission. Then he said something quietly that she would not forget. He said his wife had been bringing him his favorite sweets during hospital stays for 22 years. He said he had been admitted 11 times in those 22 years. He said he had always recovered. He said she had always been very attentive during his recoveries. He said she had always seemed very relieved when he got better. Grace stood in the doorway of the corner room on Ward C and listened to an old man describe 22 years of hospital admissions. And she thought about a woman who brought her husband his favorite sweets every time he was sick. And she thought about the smell of almonds that she had noticed from the doorway. And she thought about the word attentive. And what it meant when attentive was the word a person reached for, when the word they did not reach for was something else entirely.